Thank you for recording our meeting. Thank you all for being here. We're super excited to have all of our partners together in one room again. My name is Irene. I am the coordinator for the Immunization Coalition of Los Angeles County, and I'm also a research analyst with the LA County Department of Public Health Vaccine Preventable Disease Control Program. So really grateful to share the space with you today and share some best practices, hear from you all, and really hoping to have an engaging event. So again, thanks for your time, and I will turn it over to our coalition chair, Carrie.
Thank you so much, Irene. And thank you all again for being here. So this is our fall vaccine forum. It's really lovely to see a lot of you that we saw in the spring now joining us again in the fall. We typically have focused our fall meetings on respiratory diseases and the vaccines that prevent them. And we will have some of that today as well, but we did throw in little bit of a mixed bag on our topics. So we're gonna first go over some of the outcomes and even our partner perspectives on two of our grant-funded projects that wrapped up earlier this year. We will have some information about respiratory virus season, really front of mind for everyone. If you haven't gotten your flu, COVID, plus or minus RSV vaccines, please make a plan to do that. And then at the end, kind of our main event will be a panel discussion focused on perspectives to improve vaccine uptake and access among underserved and undervaccinated populations. So really looking forward to all of our speakers. I would also like to recognize a few individuals in the room who are members of our steering committee. You can stand up or just wave if you'd like. So I'll just go from left to right, but Susan Chidas, who's with the LA County Department of Education and a really big advocate for vaccinating students. Dr. Richard Dang in the back, who's with the School of Pharmacy at USC. And then Elsie Nash, who is, I think, our longest serving steering committee member, which is absolutely wonderful, and is also a member of Immunize LA Family. So thank you so much to our steering committee members who, along with Irene, really keep the coalition running. So wonderful to see their faces. And then I know we also have some steering committee members who may be online, and I wanted to recognize them as well. So I'll just go through the list of everybody who is a member. So we have Matt Moyer, who is with the Community Clinic Association of Los Angeles County, Reverend Danisha Beaver, who's with Charles Drew University in their School of Medicine, Payal Sahani, who is with Sahas for Cause, a Southeast Asian focused organization. We have Dr. Gina Johnson, who's a pediatrician and the pediatric medical director at Northeast Valley Health Corporation and FQHC in the Valley. And then last but not least, Isaac Cuevas, who is with the Archdiocese of Los Angeles and helping to represent the religious community in our county. We also have 3 advisory members who have been really instrumental in moving forward some of our initiatives in the very recent past. So Sean Mayer, who has been our webmaster, but is also helping us to develop funding streams and many other aspects of what we do. We also have Julissa Soto, who spoke at a coalition meeting about a year ago. She's actually from Colorado, but has a really broad wealth of experience in vaccine equity advocacy and advising. So she's one of our advisory members as well, along with our newest advisor, Jessica Revelis, who has a communications organization and will be helping us to kind of work along those lines as well. So thank you to all of our steering committee members who are here and even those who were not able to make it today. Next thing I wanted to do is bring up one of our community partners who really helped to bring one of our grant-funded projects to fruition. So B. Scott Hamilton, who's the co-founder of Better Brothers of LA, is going to be presenting with myself. We're going to talk about outcomes from our Mpox vaccine project that was completed earlier this year. There were slides for all of that. All right, so I have a few slides just to give kind of a broad overview of the project and some of our outcomes. I'm going to go really quickly because you all actually have a nice little one-pager that the CDC Foundation helped us to create. So you can take that home and get more information from it. But I really want to save a lot of time for Scott to give his perspective on the project and outcomes as his organization was involved and hopefully benefited from our project. So the objectives, we'll just discuss outcomes of the project. The impact, I think, is probably the main focus here. This project was funded by the CDC Foundation, along with a few others across the country focused on MPOX. In terms of background, I think we all have some idea what MPOX was. We were all here for the kind of double pandemic starting in spring 2022. We know that in Los Angeles County and across the US, our MSM populations were the most heavily affected, which is why we worked with organizations such as Better Brothers, who represented Latinx and our Black communities, which again, another kind of intersecting disproportionately affected group. And then we also know that vaccination is effective, but of course, only if those vaccines are received, right? So these were the objectives for our project. We really wanted to increase the availability of information, public awareness and education, confidence, and ultimately uptake. So some of those things are still, being measured and in the works, but we do have some outcomes to talk about. So we did a survey, we did an education campaign, and then also actually administered some vaccines and distributed some safer sex kits at various events earlier this year. In terms of our survey, we had about 55 responses, which is pretty good for a community-based program survey. 96% were Black or African American, 95% non-Latino, and you can see the breakdown of gender and sexual orientation there. In terms of our results, what we really, some of our most notable findings were that those who were very familiar with the vaccine were more likely to be vaccinated. Also, those who were not vaccinated either fell into kind of one of two groups, either feeling that they didn't need the vaccine or needed more information. And both of these things easily addressed through education. We also found, interestingly, that those who received their health information primarily through social media were actually more likely to be vaccinated. So this points to this being a really important resource for our communities. And some of the biggest barriers that were identified were lack of trust either in public health, in the healthcare system, and a lack sometimes of culturally responsive or sensitive or affirming healthcare. So this points to some of the gaps that we have on the healthcare provider, research, public health side. Our results were really exciting. So we did distribute a lot of educational materials. We also were able to put up 3 lovely billboards. Are they still there? Do you know?
I don't know.
Okay. Yeah, so they were all in South LA. This is one on Crenshaw and 66th. There's also a social media campaign, and you can actually still go to Instagram and check that out as well, along with a video PSA. We did administer 18 doses of the vaccine, so not a huge number, but of course every dose counts. And we distributed a good number of safe sex kits as well. So some of our conclusions just on the survey and research side, and then I will hand it over to Scott to give you, I think, more of a personal takeaway. First, that culturally relevant information is extremely important in promoting vaccine uptake. Engagement with the healthcare system, also a predictor. So those who had a regular source of care were much more likely to be vaccinated. Also, that social media is an important source of information. So not being afraid, I think those of us who are millennials and older, sometimes we're a little wary of using social media as a big educational tool, but it is really where people are receiving a lot of information. And then finally, that community-based vaccination access really can reach those who may not have had access or maybe had lacked some confidence in the vaccine previously. And now I'd like to introduce Scott Hamilton. Thank you so much for being here.
Thank you.
If you need to advance this.
I think that's it. Good morning. I'm Scott Hamilton. I'm one of the co-founders of Better Brothers LA. And we partner with ICLAC to do several different events and also get out information around MPOX. One of the things some of the things we found that we wanted to highlight was, importantly, credible messengers. We found that the community responds to messengers who shared lived experiences and have the ability to communicate information that is culturally competent. We also found that having an authentic voice, having someone to share information with an audience who understands their background, increases message infiltration, important to understanding how to simplify language for clear communication. We also found that community engagement is higher when the event is culturally tailored. We found, the community responds more to events that are tailored to their interests, including relevant topics, engaging with celebrities or social influencers. One of the events I wanted to point out was we actually partnered with Netflix on the screening of Rustin. With us being a Black LGBTQ plus organization, Bayard Rustin being a figure in the civil rights movement. And we had a discussion that included Dr. Tracy Veal, we had Keith Borkins, actually the writer of Rustin was there, and then Darren Harris, who served in capacity to when Mayor Karen Bass was in Congress, he was her chief of staff. But that event actually focused on tying social justice and health justice together and the importance of our community being represented in those different ways. So just being able to fighting for equal health equity in that instance, and also bringing home the message of the importance of monkeypox was shared there. One of the other events we did a holiday event, and we actually had on-site testing available at the site. And so one of the things we found is having resources on site at the event allowed community to take advantage of resources without them having to go somewhere else. And so we basically get them out while it's hot, having them there on site. And then, of course, social media. We did the social media campaign. After each event, we did recaps of the event. We've actually just found that, social media must be used if you want to engage your audience, especially the next and future generations. It allows the message to be shared wider into a broader audience. We also found that, those audiences look for quick ways to absorb information at their own pace, and then the content must be engaging and relevant. And then finally, food never fails. So we actually, the majority of all of our events was not geared around food, but we provided people some form of food or intake. We have a series here called Brunch, Talk, and Learn. We actually use Dr. Leo Moore, Travell Anderson, and Keith Borkins. And that was, again, one of those disparities of talking about health equity, as well as messaging around race and cultural sensibility. But yeah, so those were our findings, and I'm glad to be a part of this study with you all.
Thank you so much. Are there any questions about this grant or any of the outcomes? Okay, I will pass it then back to Irene. And thank you so much.
Thank you. Thanks so much, Carrie and Scott. So next, me and my colleague Esteban will be presenting on another grant initiative that ICLAC was involved in this year. And it was the Partnering for Vaccine Equity grant with a focus on identifying and addressing any inequities and barriers in adult influenza and COVID-19 vaccination coverage. So this was done in partnership with the Los Angeles County Department of Public Health. So a little bit of background on the grant. It was a one-year project. So this was awarded August 1st, 2023, and the project concluded at the end of July this year. And it was funded by the National Association of City and County Health Officials, NACCHO, with support from the Centers for Disease Control and Prevention as well. And the objective of this grant was to support local health departments in identifying and addressing those inequities in adult influenza and COVID-19 vaccination coverage among racial and ethnic populations. And the overall goal was to decrease any inequities in vaccine uptake in those communities. So the population of focus in LA County was Black and Latino adults aged 50 years or older living in South Los Angeles. And this population was chosen given the strong evidence that older adults are really the most vulnerable to severe outcomes from respiratory disease, and also given the disparities in health outcomes in South LA. So Los Angeles is very large, so just wanted to give you some context for where we were focusing our efforts in South LA. So in LA County, we were looking at the Service Planning Area 6, which was covering, we chose to cover about 19 zip codes that really had the lowest vaccine uptake, highest vaccine hesitancy, and other poor health outcomes. So 19 zip codes are where we focus. These are some of the cities here you'll see. So Compton, Linwood, Inglewood, Hawthorne, and the surrounding areas. And then in addition, from those selected zip codes, we were just looking at the age breakdown of the population. And so over 20% of the population in that area was age 55 and up. So that also doesn't encompass the 50 plus target population we're looking at. So it's probably a little greater than the 20%. But yep, a good majority of the population was in that older adult group as well. And so a little bit more about our target population. So South LA, as you may know, is very densely populated. There are over 1 million residents just across 15 square miles. The largest racial and ethnic groups in South LA are Latino at 60% and Black at 29%. And the region also has the highest rate of poverty in the county, with about 31% of residents living below the federal poverty line. And then in addition, education levels are low, and only about 30% of residents are without a high school diploma. And so additionally, the rate of COVID-19 mortality is also highest in South LA at about 400, almost 500 per 100,000, compared to overall in the county at 333 per 100,000. And then South LA also has the highest mortality rate for flu or pneumonia as well annually at 25 per 100,000. And then furthermore, South LA is also considered a health desert. So there is a shortage of local healthcare providers despite the high need and high levels of poverty, morbidity, and mortality. And then there are also the annual homeless count released in 2023 when this project was being planned did indicate that about 19% of all persons experiencing homelessness in the county are in South LA. And then lastly, those gaps in basic needs like housing, utilities, food, transportation, health insurance have really all created significant barriers to healthcare. And many South LA residents face low English literacy rates and also lack access to health information in their preferred language. So next, I'll turn it over to Esteban, who was involved in this part 1 phase of our project planning, which was a rapid community assessment to gather more information from the community about their barriers to vaccination. So I'll hand it over to you.
Good morning, everyone. So what were our objectives, right? So we wanted to go ahead and gather the evidence on how misinformation and other barriers influence vaccine perceptions of adults residing in South LA. And we wanted to inform and develop strategies to increase vaccine confidence and uptake, ideally. Now, identify persistent barriers to vaccine uptake among South LA residents aged 50 plus to inform outreach, communication, and other activities to improve vaccination coverage. Now, what were our methods, right? So we did a two-pronged approach. So using the template from the CDC, we were able to go ahead and conduct a community partner interview with CDU, Charles Drew University, and Kedron Mobile Health Program. Now, then afterwards, we went ahead and did a 4-pronged listening session. 2 were in English and Black faith-based communities, and then the other 2 were in Latinx communities. Our listening session partners were Charles Drew University, as I previously mentioned, Kedron Mobile, and Mujeres Extraordinarias for our nation. Now, these are the highlights, right? I think this is going to be more important as we get down a couple more slides when we get to the highlights. When we did these listening sessions, we found out that the vast majority of our participants were female. In addition to that, they were collectively representing our neighborhoods within South LA, those previously described 19 zip codes. So we felt like we had a good mix, right? And we felt like we were able to cover a widespread footprint. And on top of that, we were able to identify some certain knowledge and historical context on these preconceptions, namely that the government institutions and organizations that seek to work with communities of color need to build trust. And that idea or that concept of trust kept on pounding into us throughout this project. We've noticed that trust is at the forefront of everyone's mind and what really helps us be able to create long-lasting impacts. They needed to show up consistently, right? So everyone talked about trust throughout these listening sessions, specifically with the subject matter experts. And it's this idea that, yes, we can build trust, but we have to do it repeatedly, right? You have to make an actual presence. You have to do it more than just once. You have to show up to the community. Now, historically, these communities of color have been disproportionately impacted by a series of different medical issues. So this idea of having a strong presence was really overwhelming and a constant theme. Other highlights we noted were the lack of timely immunization information for older adults, a lack of family support to access healthcare services, including immunizations. Other things of note were community acknowledgement that we needed a lot of things. We needed more mobile vaccine clinics. We needed more vaccine information. We needed more information of the old, quote unquote, COVID and flu vaccinations and the new, quote unquote, RSV and Mpox vaccines. And we also needed more information on vaccine effectiveness. And we needed more information on resources and vaccines for seniors. Other highlights that we thought were notable were the idea that the community overall were kind of confused by the surrounding misinformation and mixed messages. Was it this? Was it that? I heard this. My provider said this. A TikTok doctor, quote unquote, said this, right? And it was a constant theme that we were able to highlight during this rapid community assessment, where different sources of information were just confusing people, and there were serious questions popping up. Also, this distrust in vaccines, mostly from the COVID-19 pandemic, right? People are like, well, I heard that because this vaccine was done super fast, that it's not actually that effective. Or I heard X, Y, and Z, right? And these preconceived notions began arising. Also, a lack of understanding of the need for multiple doses of COVID. A lot of people were bringing up the idea of, well, why do I need to get another one? I just got my 2 doses. Aren't I complete? Wait, what? I thought I was already updated. Now there's a new one? What about the old new one? And this idea of confusion kept on arising. Also, the fear of experiencing side effects. I have to work. You have to work. She has to work. We all have to work, right? I can't get sick for 2 days. I don't want to run that risk. That idea of being scared of the side effects of, oh, my body's going to be, 2, maybe even 5 days, or I'm not going to be able to work. I'm not going to feel at my greatest. I have to take care of kids. That idea kept on coming up within this community. Also, the idea of just overall negative opinions and feelings against COVID as a whole because of the pandemic. Well, there's a lot of medical and historical distrust within this community specifically. And so this idea of, well, in the past, I don't know what the government did. I don't know if this vaccine is safe. They came out with this way too fast. I don't trust this. Do you trust this? Well, my doctor doesn't even really know, or my doctor hasn't even had a chance to read, the latest immunology reports. Well, if they don't trust it, how can I trust it? This idea of distrust kept on growing. And the lack of positive perceptions of flu. Now, what did we learn from all these rapid community assessments, right? From these interviews? Well, we learned our limitations, namely that many seniors lack family or caretakers, right? The idea of, well, I can't really have someone drive me somewhere, right? That was another issue we identified, mobility issues or transportation issues. And the idea that many seniors have difficulty understanding immunization messages, period. Sometimes the complex messages are just too long, or they use words that is just health literacy, it's too high, and the overall population's health literacy might be a little bit on the lower end, and it's a issue of conflict. What did we also learn? We learned our needs. We needed to meet the community where they are, to bring resources to them. The hours work for them, right? My normal schedule is 8 to 5. Your normal schedule is 8 to 5. If we're having an event at 2 p.m., that doesn't necessarily work for our population, right? If they're still working. So meeting them not only in South LA, not only in their specific city, or their specific community center, but meeting them during their time when they're off work, when it's most appropriate, is the best approach. We also found out that the need for timely, accurate, culturally and linguistically appropriate messages for recommendations for adults. Now, within this population, as we previously mentioned, we noticed that a vast majority were Hispanic or a part of the Latinx community speaking Spanish. And it came up. Do you have a health educator who speaks Spanish? Do you have a community health educator who speaks Spanish? Oh, we only have this pamphlet in English. Can you translate it in Spanish for me, right? We also identified the need for more trusted messengers to communicate this information more widely. Once again, going with that idea of making sure we show up, making sure we're there consistently. Now, the overall attitudes, many seniors in South LA welcome the increased access to vaccines and immunization information and resources, which we think is great. And there is a widespread acceptance and interest in hearing about other vaccines, namely shingles and pneumonia, kept on populating, which we also think is great, right? Showing that they're interested in vaccines. They're not completely closed off to it. They're not 100% vaccine hesitant on this spectrum of vaccine hesitancy, but they're still willing and open to accept it. What are other concerns that we learned? Well, vaccine hesitancy is connected to a lack of clarity about what vaccines are and how they actually work, right? And overall confusion about the number of doses needed for COVID-19 contributes to the skepticism regarding its overall effectiveness. I'll pass it back to Irene.
Thank you. Great. So phase 2 was really implementing our intervention, which was the coordination of community vaccine events in South LA. So this is an overview of our intervention planning process. So, as Esteban just gave an overview of the rapid community assessment, that was really our footprint for how we plan these events and the type of resources we have available at the events. Additionally, the listening session findings were used to help inform creation of immunization booklets that were targeting older adults that were available in English and Spanish. So those were items that were distributed at our community vaccine events. And then secondly, we did also identify and collaborate with a subject matter expert and trainer. So we did have a trainer provide a cultural validation training to our community health worker team and staff that were going to be at the community vaccine events, just generally about best practices for immunization and communication, how to message and engage with the community, and then strategies for addressing vaccine hesitancy based on what we were hearing from the listening sessions. And then we identified and trained local community health workers. So these community health workers attended the events. They were encouraging folks to get vaccinated at the mobile clinic. They offered guidance, shared referrals to local vaccine clinics, and also answered any questions folks had as well, in addition to distributing various printed resources. And then lastly, we worked to identify these 7 community locations across South LA where we could have the mobile clinic as well as additional resources available. So the mobile vaccination clinic included offering COVID-19, influenza, and any other vaccines that were requested by the host site. So we did also offer Mpox and Hep A at some locations. And we work closely with our internal Department of Public Health mobile vaccine team and our community partners to have other resources available at these events. So it wasn't just a mobile vaccination clinic, but there were also health screenings available. We partnered with sites that were offering recurring food distribution events, partners that could offer health insurance enrollment, mental health resources, and health fairs. And while we were there and present with the community, we were also able to gather community assessment surveys. So further assessing just what the healthcare needs are in South LA, including immunizations, but other health needs as well. And just, how folks are accessing their vaccine information. So some materials we developed, this is the immunization booklet I mentioned, specific to older adults. So these were distributed and had vaccine resources and other resources as well for older adults, including health and aging services and mental health services. These were just our event-specific flyers that we shared with partners and posted to promote each vaccine event in the community. So these were posted on our webpage, social media, and community calendar. And then lastly, we did also have some promotional items like gloves, scarves, and cooler bags purchased. Due to our grant timeline, our implementation of this intervention had to be pushed back, and we didn't get those materials in time, so they were more focused for the winter. We held our vaccine events in the summer, but we are hoping to use those this fall, as well as vaccine incentives. And then lastly, other things that we handed out, tote bags, which you all saw, and we have some available for you today, hand sanitizer, masks, little giveaways to encourage people to come visit us, talk to us, even if they don't get vaccinated, just to engage with us and help us complete the community assessment survey as well. And then these are all of our wonderful partners. As you know, ICLAC was really the main lead and subcontractor on implementing all these activities. We worked with our community clinic partners, St. John's and Venice Family Clinic, faith-based organizations, nonprofits, Julissa Soto, Latino Health Equity Consulting, who is our cultural validation trainer, the Department of Mental Health, our mobile vaccine team, the Department of Aging, and then Charles Street University and Kedron Mobile Health Outreach Team as well. In addition to just senior housing providers too, which is where we held one of our events. So all of these partners either helped us identify locations for the events, let us know that they're hosting a health fair and invited us to join and be present with our mobile clinic and community health workers, or they came to other scheduled events and offered their resources. So really great partnership. And then our outcomes. So these are all of our 7 events. I won't go through them, but you can see it was really a wide variety of food distribution events, locations at faith-based, with faith-based partners at a couple of churches, senior housing, and then also transitional care as well. And overall, we engaged with almost 1,000 attendees across the 7 events. And we administered 90 total doses. So majority of those were COVID-19 doses, which we were happy with. And then also some influenza, Mpox, and Hep A as well. And then 30 individuals also had some sort of health screening completed, either a blood pressure check or a TB test or a physician consult. And then, about 1,300 printed materials were distributed during these 7 events, and these happened over the course of about 4 weeks. And then lastly, we collected 171 community assessment surveys. 93 were in English, 78 were completed in Spanish. And in your welcome packet, there is a report summary included, so it has a lot more information about the findings from that community assessment survey, more information about just our grant project and more outcomes that hopefully you'll be able to look at and get some more information, since this was just a really high level overview. But I think this is it. I just have some photos and happy to take questions. If for those online on Zoom, please raise your hand or enter your question in the chat. We can unmute you or read the question out loud from the chat, and then welcome any questions or thoughts or other perspectives from this group as well before we take our break. Vaccinated, were just thanking us for being there. So that was really notable, and saying that they're grateful that we're there to just be a presence and to offer help, even if it was directing them to health screenings or providing other information outside of vaccine. Sorry, I think we got disconnected from Zoom, so I'm trying to get connected. And then the food distribution events, there are so many people that come to those events on a regular basis. So that was just a really good interaction point as well to reach the most folks. And people were also really grateful for the resources available there. So that was pretty memorable. And I would say those food distribution sites and the health events were really the most impactful. Thank you for that question.
Thanks, I have a question. Since there were seniors, were most of them covered by Medicare? And I'm curious, like how that, if access was the bigger, I guess, I'm trying to think of my question, was access the bigger issue, or was attitudes and like the bigger issue that kind of came up? And I'm just thinking about like seniors, often do have a lot of medical issues, so they are seeing maybe doctors more than the general population. And would most 65 or older have Medicare that would be kind of routinely offering these vaccines? I guess I just don't have not having good knowledge of that region and that kind of population.
So we did find that most folks we interacted with did have Medicare, were insured. There was a subset of people who we gathered community assessment surveys from that were not insured at all. And so I think at our events, it was an interesting time because it was kind of off season. I know there was an additional dose that had been recently recommended for those 65 plus. So that's what we were working off of to encourage those folks that haven't received that second dose to get that. But we found that either folks were, a lot of folks were already up to date and had received that second dose, or they just really weren't interested at all in getting vaccinated. And it would stop by our table, but it would kind of share some of the hesitancies, like, oh, I don't want to put anything like foreign in my body, and just, I'm all holistic, things like that are some of the things we heard. So majority were really actually up to date, but I think that might be skewed because we were at like health kind of centered events. So maybe more folks that are just health conscious and tracking those things and take their health as priority are attending those. But many were up to date actually, or just really not interested in getting vaccinated. But we did get a few who were like, they weren't. They're like, okay, great, I'm here, I'll do it.
Thank you.
Yeah. Any other questions? Yeah, please, take a look at that report. If it sparks any other questions, or you'd like to chat with us during our networking session at the end, happy to chat more and answer any questions. But thank you, great. So we'll, I think we'll move into our break next. If there are no other questions before we end, and we'll have it till about 11 o'clock. So 10 minutes, and then we'll get started with our next presenters at 11. Thank you. As well as the 24-25 updated recommendations for this fall. So with that, I will hand it over to our first presenter.
Morning, everyone. Can you hear me okay? Okay. So I realize this is a little bit different from some of the other presentations, but we thought it would be helpful to give an overview of what's going on with avian influenza, just because it's been in the news. We now have some positive herds in California, and just in case this does become something that we do need to give a specific vaccine for, we thought it would be helpful to kind of give an overview and allow you all to ask questions. So before I get into avian flu specifically, I wanted to give a little bit of an overview about flu in general. There are 4 types of flu viruses, typically categorized as A, B, C, and D. And the ones we usually think about seasonally causing hospitalizations are flu A and flu B. And Dr. Yeganeh is going to talk a little bit about the vaccines for those viruses, are seasonal viruses. But the flu A is really the only flu that causes these big epidemics. So if you remember, H1N1 back in 2009 caused a pandemic, and then the 1918 flu was also a flu A. So typically those are the ones that cause these pandemics. And the flu A viruses are categorized based off of the H component and the N component. And these are proteins on the outside of the virus. I don't know if this is yes, this is the pointer. And so you can see that the hemagglutinin is in the blue and their neuraminidase is in the red. And that's how we characterize them. And they can change the types of H and N, which makes them, sometimes more evasive of the vaccines and can cause pandemics. And there are 18 different types of H types and 11 different N types. And this is just a diagram because I think sometimes it's hard to understand how these mutations occur. And with flu, specifically flu A, we think about antigenic drift, which is when there's small mutations, kind of like what we get with COVID. You know, the vaccine makes more, or the virus rather, makes more copies of itself. And then that leads to mutations because they make some errors in making these new copies. But antigenic shift is what we kind of worry about a little bit more with these pandemics for flu. And that happens when you have a virus, say a bird flu virus, where you have this intermediate host, for lack of a better word, that gets infected with, say, a bird flu virus and a human virus. And then it kind of causes this shift where there's reassortment and this completely new virus that looks very different from the bird virus and the human virus, and humans aren't immune to it previously. So that's kind of what happened with H1N1. We had a pig virus that combined with a human virus and led to a new virus which people hadn't seen before, and then were at increased risk of severe disease. So just a little bit about bird flu in birds. So avian flu is a type of influenza A virus. And these viruses occur most of the time kind of undetected in birds. There's over 100 different species of wild birds globally that can become infected with flu A. And it occurs naturally, typically among these aquatic birds like ducks and things like that. Some species don't really get that sick from flu A, although it is really contagious among these birds, and they tend to shed it kind of in their saliva, their nasal secretions, and their feces. And I kind of want to go over these two different types of avian flu, because I think sometimes we hear the word highly pathogenic and we think, oh my gosh, this is really severe in humans, but actually it's referring to the disease in birds. So there's low pathogenicity avian flu, which is most of these flu A viruses. They don't cause much disease in birds. They get, infected. It's no big deal. But with highly pathogenic avian influenza, it can cause really severe disease. And we typically think about it causing severe disease in poultry. So if you remember, I think it was a year or two ago, there was a really dramatic increase in the price of eggs. And part of that was because these birds, these chickens would get infected, and then they have really high mortality. They also tend to lay fewer eggs, and so that drove up the price of eggs. And in addition, when it's identified in chickens, they actually have to depopulate, which is kind of a euphemism for kill all the other birds that have been exposed, because you don't want it spreading among those birds. The challenge is that it can spill back into wild birds. So if you have a bunch of chickens on a farm and there's a pigeon or a duck nearby that flies in, it can get into the wild bird population. So it's been circulating, H5N1 has been circulating among wild birds and poultry since 2020, and in the US since 2021-23. And this is kind of what we've been seeing. We see these outbreaks typically when there's migration of these birds, and they get together, and then we can see some of these outbreaks among the birds. And we've had over 10,000 wild birds that have tested positive, and over 100 million poultry. The reason so many poultry get infected is, they're very confined. They can easily transmit the virus to one another. And there has been sporadic transmission from these poultry to humans. In 2022, there was a poultry worker in Colorado who had been at one of these farms that had been infected and had been doing some depopulation and got some symptoms really just of fatigue, and they tested positive for the virus, for the H5N1. But we hadn't really seen any other cases in the US since 2022. So the one good thing about H5N1 is that there hasn't been evidence of sustained human-to-human transmission. So there's a lot of transmission among birds, but for example, this one Colorado case didn't go on to infect anyone else. And so from what we know right now, it doesn't seem like the virus transmits easily from person to person after someone is infected. As far as the symptoms and severity, there are typically just similar to flu. People get fever, they get chills, they get some sore throat. We'll say one thing that has been noted with this particular outbreak that we're seeing right now is a lot of people are getting conjunctivitis. So I think part of that reason is the way they're getting infected, and we'll talk a little bit more about that. But some people are just presenting with red eyes and no other flu symptoms. And then you can certainly get GI symptoms and muscle aches, just like with flu. And the cases as part of this outbreak have really been mild. No one's had severe disease. But globally, when there have been different strains in the past, the mortality has been really much higher. The case fatality rate has been around 52%, but this strain is a little bit different. And then the treatment, fortunately, is just the same as our treatment for regular flu, which is Tamiflu or oseltamivir. So let me tell you a little bit about the current outbreak in the United States. So on April 1st, CDC confirmed one human H5N1 infection in somebody who had occupational exposure to infected cows in Texas. So we knew back in March that there was a farm where there were some cows that had become infected with H5N1. And that was kind of the first time we'd seen domestic mammals like cows that interact closely with humans becoming infected and then transmitting to a human. And so the reason this is concerning is that, you know, as I showed you in the earlier slides, if you have an animal that becomes infected and is in close contact with humans, could that person become infected with seasonal flu and with this H5N1, and then you get reassortment and then a potentially more infectious virus? Or also, the more times mammals get infected, or humans, the more likely the virus is to kind of adapt and mutate and potentially lead to new strains. So currently with our H5, there have been over 230 cattle herds in 14 states that have tested positive. There are 43 herds in California that have tested positive. And part of the reason we're seeing so many cases in cows is that the cows actually are moved frequently among states and within states. And you might have an infected cow that goes to a new farm, is in close contact with other cows, or you know, we know this virus is in the milk, and when they milk the cows, they reuse the same milking equipment on cows. They might be transmitting the virus through milk to other cows. We've also had 14 human cases in the United States. 4 of these cases were following exposure to infected cows, and 9 were following exposure to poultry. And then recently, in the past month, there was one case that was identified in Missouri who didn't have any known exposure to animals. It sounds like this case was picked up because they tested positive for flu A. Somebody sent that specimen to the state for further testing to see if that was H5N1, but it was just kind of part of their routine surveillance, and they found that it was positive for this H5N1. So that is certainly concerning, but when they've done further analysis on it, it doesn't seem like there are any mutations that might suggest this is more transmissible, but they still haven't figured out how this case became infected. They're also testing some healthcare workers that interacted with this case in Missouri because they've become symptomatic, and they're not sure if these healthcare workers were exposed to H5N1, and so they're doing more testing on them to kind of see if they're infected. This is a map of the detections in cattle. California, as you can see here, is one of the more affected states, and I learned through the course of this that actually California is the top milk producer in the country. So it's not surprising that we have a lot of positive dairy farms. And then I just found out this morning that there's actually a case that they're investigating right now who was exposed to cows in the Central Valley and is being investigated for H5N1 and they think might be positive. They also presented with red eyes. So it's also not surprising because, you know, the more people you have exposed to cows that have the virus in their milk, the more likely we are to have some transmission to humans. As far as in LA County, we've only had 2 wild birds test positive for H5N1. We have one dairy farm in LA County. I don't know if anybody knew that, but it's in the Antelope Valley. And thus far, we haven't had any mammals test positive or cows test positive. We are doing some routine surveillance in, you know, cats, for example, that die and have neurologic symptoms because the virus can potentially infect them. And we're doing other routine testing. We also do wastewater testing. We haven't seen any detections of H5N1 in our wastewater. And I didn't get a chance to update this slide, but as of now, they're investigating a human case in California, but we haven't had any cases in humans in LA County. So wanted to talk to you a little bit about avian flu vaccines for humans, because there is the possibility that if this becomes a bigger public health threat, that we might need to vaccinate people who are at risk of being exposed. So currently, just to be clear, there is no avian flu vaccine available for somebody who is at risk. It's not yet been distributed. It would be up to you know, the federal government to decide when to distribute that vaccine and to get emergency use authorization for it. But we do have vaccine that are being stockpiled for this should it become a public health threat. So the US government creates these vaccines should there be any public health threat, and they do it in advance so we're not rushing at the last minute. So they do have some stockpiled H5N8 vaccines, and those are expected to generate cross-protective antibodies against H5N1. And then we also have H5N1 vaccine that is stockpiled as well. And the FDA is meeting on the 10th, so in a week, to discuss more specific vaccines that are similar to that strain. And then certain executives at GSK, Moderna, and other pharmaceutical companies are developing further vaccines. And they say that production of additional vaccines could take as many as 6 months. So the good news is we do have vaccines that are available that would protect against the strain, although it's not available currently. And I think that's one of the take-home messages. They're also looking at vaccines for poultry. I realize we're only focused on humans, but they are looking at vaccines for poultry and for cattle. This is, of course, all being investigated by USDA. So as far as what LA County Public Health is doing, so we're doing a lot of outreach for providers to make sure that when they see somebody who they think might have flu, to ask them about animal exposure. We are also educating people who come in contact with cattle and with poultry. One of the things we're doing is offering seasonal flu vaccine to those individuals. And part of that is because we don't want them to get infected with flu A that's seasonal and then this H5N1 and then get reassortment. And then we're giving them PPE, so masks and gloves and things like that to protect them should they get in contact with infected animals. And then we're doing a lot of surveillance. So we are looking at our wastewater to see if we have any detections of H5N1. We're increasing subtyping. So we actually, our lab reaches out to hospitals and other laboratories, and they get a subset of their flu samples to then sequence and see, are there any strains that maybe we wouldn't have picked up otherwise, just like they did in Missouri, that are positive for the H5N1. And then when we do have somebody who we find out was exposed to, say, a wild bird with H5N1 or a chicken with H5N1, then we monitor them and we send them a survey every day to see if they develop symptoms. And then if they were to develop symptoms, we would give them Tamiflu and we would give them isolation instructions. And then as far as preparedness, we are stocking antivirals and PPE, and then we would also be involved in avian flu vaccine distribution. And I think this is definitely an area in which we would need everyone's help, because a lot of the people who are working in these high-risk settings may have some vaccine hesitancy and are certainly at greater risk, and we would need the entire community to help us support and promote vaccination in this population.
Yeah, okay.
So I was
Wait,
just-
hold on, wait.
I like that flash mob. But I also just wanted to see if anybody had any questions before we go on to just one other quick topic that's kind of a hot topic in LA County. Any questions about bird flu or? Okay. All right. The other thing I just wanted to mention is hepatitis A, because we've seen an increase in cases of hepatitis A in LA County, particularly among people experiencing homelessness, and including 14 people who use drugs. And so we'd like to just make everyone aware of this outbreak if you haven't seen it in the news. 6 cases were in people who did not have risk factors, but once we did some further testing of the virus strains, we noted that they were similar to those of people who experienced homelessness or used drugs. And so we want to be sure that, you know, providers are aware of this and that they know to test for hepatitis A and identify cases and report them so that we can vaccinate those people they've been in close contact with. And then to promote vaccines among people who are at risk, so people who use drugs or people experiencing homelessness. It is now universal for younger individuals, but there are certain older individuals who may not have been vaccinated in the past. So thank you.
That was great. I know that are we short on time maybe? We have a few minutes, so I'll just go over maybe my slide about what respiratory viruses we do have. So as Dr. DeSimarie said, we are very closely monitoring our vaccine for avian flu and the disease itself. But at this point, we don't have a vaccine, but we do have really important vaccines to help protect everyone against respiratory viruses. So the first one, of course, is the flu and COVID vaccines. The flu vaccine is protecting against 3 different strains of flu, 2 flu A, 1 flu B, and it is recommended for everyone 6 months of age and older. Those who are over the age of 65 should get the high dose, and then there's some recommendations around people who are immunocompromised. Those who are under the age of 9 and have not received the flu vaccine before would also get 2 doses. So definitely talk to your provider. There's very specific recommendations. We have a website, ph.lacounty/vaccines, that has a lot of this information and nuances. As far as COVID-19 vaccine, it is an updated vaccine. We have different manufacturers. I know we heard a lot about vaccine hesitancy and confidence around COVID-19 vaccine. I do want to say that we have 2 mRNA platform vaccines and 1 that's recombinant vaccine, Novavax. So if you do come across people who don't want to get an mRNA vaccine because they do feel sick afterwards or it affects them so they can't take care of their kids and go to work, they can try the Novavax vaccine, which should be available at a lot of different providers and also can be available at our public health centers under the VFA program as well. As far as RSV, there's two different methods to immunize infants. They're similar to last year, but hopefully we won't have any issues with supply this year. The first one is vaccinating a pregnant person during week 32 to 36 weeks of pregnancy. And this would be from September 1st to the end of January. This way the pregnant person would then develop antibodies and then be able to immunize the newborn. Again, this seems to be a really wonderful way to provide the newborn protection for the first few months of life. The second way is to actually immunize the infant. So you would give nirsevimab, which is a monoclonal antibody. I think the name is Beyfortus, and I've heard some commercials on different channels. I think it's supposed to be like before Beyfortus, before they get RSV, and so this is supposed to protect them, and it does really. This specific monoclonal antibody preliminary data suggests that it's 91% effective against RSV. For those of you who don't have children or are not around pediatrics, RSV is the #1 cause of hospitalization in infants, and definitely causes very severe disease, even if they don't get hospitalized. So this is really a game changer for us who care for infants. And then last but not least, we have RSV vaccines for older adults who haven't received an RSV vaccine before. So those who received an immunization product last year are done. It seems like the protection does last at least 2 years. But for those who did not get the immunization or the vaccine last year, they would be eligible for 3 different doses if they're, 3 different vaccine products if they're 75 years of age and older, or if they're age 60 to 74 years of age and are at high risk for severe RSV. This would include anyone who's 60 years of age and older and lives in a long-term care facility, in a skilled nursing facility, or has underlying conditions affecting their kidneys, their lungs, or any other major organ, including people who have diabetes mellitus or cardiac conditions. The 3 different products include an mRNA vaccine and then 2 recombinant vaccines. So really exciting that we have all these different products available. And I'm happy to take any questions. We have a lot of resources on our website. ph.lacounty.gov/vaccines. We have information for priority populations. We have recommendations and information about different vaccine preventable diseases. We have locations where you can get your vaccines. We have information on respiratory illnesses and what we're seeing in Los Angeles County. We have data about where we're seeing gaps in coverage for COVID-19, as well as school immunization coverage data. So lots of information on our webpage. So if you have any feedback for us, and if there's other products you would like to see, please let us know. We were just talking that maybe today we have a new product about vaccine misinformation, disinformation, common myths, to create resources for people who are encountering this, and some information about that. So if there's anything else, please let us know.
Thank you so much. I think we'll just take a quick 5-minute stretch break, let our panelists come up to the front and get settled, and then we'll get started in just a few minutes with our panel discussion. So quick 5-minute stretch break, and then we'll get started. Thank you. 2 years. He's currently on the ICLAC steering committee and is also the vice chair of the Immunize LA Families Coalition as well. And additionally, she's on the local Immunization Coalition leadership team for the California Immunization Coalition. So really grateful to have her. She is also a martial arts instructor and 3rd-degree black belt, which is super impressive. So make sure you stay on Elsie's good side. And yeah, thank you, Elsie, for being here. And then our 3 panelists, first panelist is Pedro Martinez, and he is the Director of Health at Unidos US. He is, sorry, I don't have my glasses. He also co-leads a CDC-funded initiative aimed at reducing racial and ethnic disparities in immunization rates among Latino communities across the lifespan. He has over 15 years of experience in public health, centered on delivering program development, scientific guidance, and capacity building, all at the local, county, state, and federal levels. So really excited to have him present. And then next we have Jacqueline DuPont Walker. And she is the founding president of the Ward Economic Development Corporation, which is a 35-year-old community-based faith-centered development organization serving South Los Angeles. And currently, Ms. DuPont Walker is a member of the Payne Seminary Board of Trustees, and she's also on the Metro Board. So really grateful to have her here as well. And then Dr. Jerry Abraham may be joining us a little bit late. He is coming from another meeting, so hopefully he is able to make it today. And he is the former president of the Los Angeles County Medical Association and current director of Integration and Public Health at Kedron Community Health Center. So really great team here, and I will hand it over to Elsie to lead us through the panel discussion. Thank you.
Thank you so much, Irene. So I like to fight, as you know. But not just as a martial artist, but also in our community to prevent diseases that save lives. So that Jack's is doing the same. So what we're going to do is have panel questions revolving around 3 different sections. One is in investing in trust building. The second is addressing root causes of inequities, and the third is planning for sustainability. So for our panelists, our first question is, how do you identify, engage, and support trusted cultural messengers to ensure they can effectively convey accurate vaccine information?
All right. Bring it a little bit closer. Hi everyone, my name is Pedro. Such a pleasure to be with you today. To just share a little bit about the School After Foundation, largest Latino nonprofit government board. I'm based in Washington, D.C. I get an opportunity to work here from California. And part of the work that we've done over the pandemic is we were applying for a which is a $23 million investment to fund our community-based board to be able to conduct targeted messages for those community and work to also develop their own education campaign, because we know that our community works that and not all communities are the same. So we can't do one size fits all. We have to allow our community work to tailor their approaches. And in terms of identifying trusted messengers, many of the community work that we funded utilized their everyday messengers. What do I mean by that? Street vendors, faith leaders, community health workers, and so forth, who are already embedded in the community. One of the reasons why community-based boards were able to not only just make a contribution, but a significant contribution in reducing the vaccine disparity gap over the pandemic, especially early on in the first round series of COVID vaccine, is because our community works understand which of their trusted messengers were being effective. And in the communities that the community funded, specifically here in California, you all may have heard of a wonderful organization called Health and Mental Health Services. They were one of the recipients of our funding, and what they did is that they developed a campaign called Vendedores Empoderados, which is street vendors and health street vendors. So they already knew that out in the community as an access point for food, for products. So they trained their street vendors to be able to be trusted messengers by providing them with educational materials, providing training, and also keeping those training materials and then public information up to date. Another org close to home here in LA, including and they're in the FQHC that also works with their faith leaders to be able to train them, to be able to utilize these technology during the gathering and also prayer services. So it's leveraging the points in time and the places and locations where communities reside and where they work, live, play, and pray. That is where you're able to have the most effective approach. And targeting, I would say, vaccine information, communicating public health updates, and just having conversations with people, because at the end of the day, we all need to be active listeners and make their concerns, validate their concerns, and be able to bring them accurate information of the dialogue with the patient. And I'm looking confident in one conversation, go to the series of communication. So that is where our trust messengers must find the resilience, keep pushing, and we need to find opportunities for them so that when the resilience continues and increases, we need to. Thank you.
You. Good morning. Good morning. This is a call and response. Thank you for the opportunity to be here. That I have been introduced to the Immunization Coalition of that county. You may think that I came to talk about immunization. It's an important topic. I came to talk to you about that with and trusted with I was that everything that my co-founder said absolutely correct. But as one who has been in the trenches for a long time, I would say to you, it's not a drop in rock. It's when we communicate, attempt to communicate in communities where many promises have been made and many not kept. It means the trust messengers of people who have been there for long. We all now talk about diversity, equity, and inclusion, right? How long do you think it's been around? Give me a date.
5 years.
How long?
5 years.
5 years. How many agree with that? Nobody's gonna agree. He was brave enough to get 5 years. I mean, I agree with it. Research shows it was reported in the 1960s. What we have done is rename it. We used to call it racism, we used to call it equality, we used to call it social. So I think we have positive messages or people who connect the dots, because many people who have suffered in communities from health inequities understand. I moved to London in 1974. One of the first things I did in South LA. I went to retreat in Dr. Martin Luther King Hospital. And as everyone knows that even despite the fact that it's a health institution, they had to fight to get it. You know how long the fight took? More than 20 years. As people were looking. So trusted messengers are people who don't go away. So let me tell you about some people who don't go away. They're community leaders who make bricks without cross. That analogy means most often I'm told in the art of making bricks, you need straws. But these are people who understand that without the straws, the bricks will still be made. And I will tell you that some of those bricks in Zambia that have been there for eons, and they have remained because of the care that was put in. Each one of you has to be a trusted messenger. After all, you're going out and you're giving messages about health. I will say to you that the one thing the pandemic did that was positive is to create an atmosphere where people ask about their vaccines. So as a trusted messenger, it can't just be about what happened for those 3 years, it's decades out of my life. But it has to be about how we carry that over. So we engage with them by being consistent, coming back, meeting the needs, helping to resource the people who are those trusted messengers. And they come in all shapes and colors. I will tell you some of the trusted messengers in many of the communities that we call disadvantaged. How many people believe they represent disadvantaged people? Nobody? We got to do that. Because the people represent disadvantaged communities should be here with us. Because we can't have a conversation about how to do things better without having the on-time feedback. And so I say to you that during the pandemic, time about the pandemic, and we provided affordable housing. And I would say about 600 of the residents by affordable housing communities are elders, age 62 and above. That's when they were free. And so we understood that there was an issue. And people look at us because we had never been just about life and making sure that always the best quality of life. They look at what you want to do. And what do we, because we are the trusted messenger. Where are we going? We've heard about Kennedy. I knew about Kennedy, but we heard about Kennedy and the operation they had. Why was Kennedy strategic at that point, if you remember? It was in a disadvantaged communities where health inequities had been documented, and supposedly the resource was to be made available to the first, right? What happened? Do you remember? People from everywhere else came and took the line, right? Completely. The people who lived in the community who was intended to be reached could not. So someone told us about Kennedy. And we called. And we met Dr. Abraham. And we looked at the lines. We said, our people can't get into the lines. So we developed our own 21st century underground railroad. People would call us, we would register them. And Kedron. We would send them by lift. It was their underground railroad. They would walk to the line, they would say, I'm looking for Muhammad. And they would say, go over there. That was a senior code word. When we went over there, they would bring them in first. Wait that long line to wrap around the block. They had a place for the elders to sit, where they could listen to music and their choice, jazz or the hymns. And then 15 minutes went up, we called them again and they went home. That spread. And so they became the trusted. They would never call us. And so for us and all of you, it's when you find the people who can experience it, carry the word back to trusted voice. Yes, I believe in the faith leaders. Yes, I believe in the teachers. Yes, I believe in the doctors. Yes, I believe in the nurses. But we win when we see every potential to get the word out. And so I say to you, as we look at the season in 2024, we have had people come and ask us, where is my flu shot? Where is my COVID shot? And where is my RSV shot? We can take advantage of this season that people now and remember the last 3 years. We can do our jobs better in terms of health. When we understand the trusted voices are there, everywhere we go, let me be clear, everywhere we go, and I like to say the barbershop and the beauty salon, because all the world's problems get solved. I don't know about you, but I can do this. And they're the best solution. Those are the places we can go and hang out. We can equip the beauticians and the barbers with that information, and we can go speed down. So when they get stuck trying to carry the message, we can absolutely go and rescue them and be present. And so I think wherever we are in our communities, especially disadvantaged communities, it's extremely important to understand that trusted messaging is not a job, it's all of us.
That's great. Thank you. Yes, there was a follow-up question, but you both pretty much answered it, but I want everyone to know that the follow-up question is, what are some strategies you have found successful in bringing community members to the table and getting them involved in shared decision-making? So the fact that it's shared that already gives us ideas as well as community outreach people to reach and expand our message to a diverse area, you know what I mean? So, yes.
Something that happened during the pandemic, and I think that's gonna be in our nexus for a while. UCLA convened a group of community leaders from diverse geographies, gender, age, and culture. And they provided us with information to counter the misinformation. So wherever we came from, some came from health clinics, some came from housing on the base, some came from faith organization. And over the period of 2 years, they provided us with good information. And they were available. I don't know if any other institution did that, but we just disbanded a year ago. So we were post-official pandemic, but we had a comfort in saying, I have the latest information.
I think that was probably the first opportunity I had to really have as to that level of expertise.
That's phenomenal. Yes, and so, I know on my end, being a martial artist in a dojo, we all breathe together, we work out together, we fight together, which means we need to be immunized. So that has been a topic as well, even in this martial arts community. So, okay, so for the next section, addressing root causes of inequities. What methods has your organization implemented to deliver vaccines in community settings? And how have these methods improved access and uptake?
Public health will be at a clinic, one dose with 120 families plus community. Tuesday, there'll be a Rosa Parks dose with 60 families plus community, and Friday, there'll be a Casa de Rosas with 37 families plus community. That is a very valuable resource. I'm curious though, because even as LA County now becomes a primary source, we still have pharmacies that are calling us, who were contracted providers earlier. And the pharmacists actually have little perks of different. They have swag. Well, the pharmacists, they have free tests and they have free produce. So that sometimes makes a difference. And like, you know, my constituents, when you have this swag, these are my little ladies with this bag, and you're my church people. You're some swag. And let me add my own personal swag. I can be the medical board. I have cat cards for you. So everyone can kind of get it. I wish it was loaded. And then those are the things. So as they did ask for the clinics in Florida, we also provide information and context for community-based organizations and churches who want to have those clinics. Tying the health, physical and mental health to the mission of each organization group footprint. And so what we're talking about in our school, and when we say to our seniors, the clinic coming, we say invite your care provider, invite your family, invite anybody who will affect you. We say for small businesses, please be a part. So that's the part of it, but we believe it's not enough. And I will say my frustration is that we have a system that will only talk about COVID and only bring vaccine for COVID. We have now a captive audience where you can actually talk about health. As Dr. Abraham did while he was given the COVID shot, he would look down and say, "Oh, your mom was a little puffy. When did you see your doctor?" And by the time they left, they had an appointment to see their primary care physician. I think that's opportunity to be best to holistically deal with and how people understand wellness as opposed to simply responding to symptoms. And I think that's where we want to go in the future. Find that opportunity. St. John's will come with their mobile unit, which is extremely important. I think Kendrick will have a mobile unit. That's extremely important. One of our communities is a veterans facility. We don't presume that will cause the veterans. They have full benefits. You have something to say? Okay, I'd like to say it.
Yes, and to that point, it is true that there has to be at least one thing that will be the driver to open up the door for all the rest of the immunizations and, like you said, the holistic approach and looking at overall health. So that is a great point that you made. Thank you.
Sure, a few points. You know, one of the realities when we think about the inequities related to vaccine is we like to use the word vaccine hesitancy as I feel like in a one-dimensional manner that it's just that we're stuck at it's because I don't believe in a vaccine or if I don't understand the development of the vaccine, sort of into the career space where they're not addressing other systemic issues. How about the fact that whether I'm working parents or a single person just trying to survive and bring people kind of and working two jobs and then you know them food. Or if I'm a single parent and I need childcare and I don't have the ability to pay for babysitter because there is no childcare, appropriate childcare in the nation, support systems. How about the fact that you're a caregiver as well for your older adult? There's the list of systemic barriers and issues are plenty. So when we talk about vaccine hesitancy, we also need to talk about the systemic issues that are on play that don't allow our community to be able to even think beyond the day to day, let alone, how am I going to prepare myself for the next season? Similar to that with preparedness. If I can't survive today, how am I going to prepare for that comes every day? I face my own version of that. So because we know these things, one of the tactics that I would say in addressing some of these iniquities is to, again, we've talked about it already, meeting where they both are geographically and culturally through holding events that resonate with their daily lives to foster vaccine acceptance and accessibility. What do we mean by that? We can give an example in Redwood Christian Immunization, Florida. They primarily serve in minor communities. So what they did was they couldn't just give them a hotline or assessment employment pharmacy because migrant workers aren't working their typical 9 to 5 jobs. So they were able to utilize the funding we provided to bring them to a clinic to on site where our community members and migrant workers were at. That means having those mobile clinic show up at 3 a.m. or show up at 6 p.m. Right? Or it's the opening and ending shift of when the patient changes through. Another I would say example elevated from a 95 foot or they host the cultural health fairs, which are combined with cultural health fairs combined with vaccination opportunities. So they bring in the health fair, they bring in Zumba classes, food markets, food pantries, and then they might have a little stand where they can talk about vaccine. They can also be back in early days of the pandemic, vaccinate folks on site, or they'll be able to provide a referral set. So again, how do we address these inequities is by meeting the communities where they work with play leadership, by creating opportunities for them to be able to engage with their day-to-day life in addition to promoting. So there's just some examples.
That is very helpful. Just to kind of chime in, I have asked that question as far as why, because there's this large institution and they could not get people to get in, come back for their second dose of anything. Second dose, first dose they got it, but second dose, third dose, for whatever reason, the patients were not coming back. And so I said, okay, so what exactly is a barrier to immunizations? And they said, well, do you have unpassed? Because some of them just don't have place. They're coming from the valley and they can't get to where they need to go. And then they even elaborated and said the ones that do make it down, we're talking they don't even have a baby carrier. They're holding the baby with no baby carrier. So these are kind of the challenges that are out there, and it's great that you find some solutions to increase uptake and increase these immunization rates. So thank you. So now the next section is planning for sustainability. So the question is, how do you measure the success of your outreach efforts and partnership? And what steps do you take to ensure that improvement in vaccine confidence and uptake are sustainable in the long term?
I think one of the lessons that we've learned is building a continuous feedback mechanism, not just engaging with driving them. So what does that mean? That means that we have a lifeline to the community. We're able to understand and ensure that our outreach remains responsive to our community needs, because community needs evolve over time. You know, we're not static, right? We're humans, you know, everything is constantly changing or changing. And long-term success is not just about, you know, tracking vaccine numbers, shot in arm, but it's also how do we continue to foster and sustain our trust and engagement throughout ongoing, you know, community feedback and support. And I can give you just one quick example here from CMAR Community Health Centers, one of our FQHCs that we fund up in Washington State. They conduct surveys they train their promotoras or the community health workers to go out to the communities to drive conversations, but also track the themes of misinformation, the themes of the conversations. Those data points go back to the FQHC so that they can learn and be able to create broader materials that are addressing some of those myths, some of those, you know, I would say unknown from the community and as well as their concerns. And by assessing these surveys, that's how they were able to continue to build confidence in their communities, because they were able to uptake that information and respond appropriately, and also change their approach as the needs and the concerns of the community change.
Thank you.
I think it's just one of the and sometimes the group is because we have not set goals. For us, as a community-based development organization, our success is tied to residents actually initiating the same kinds of activities on their own. And so in the 250,000 resident area, it's important to us how many other organizations and groups ask us how to do the same thing and replicating in many instances doing that. Quantitatively measuring it, we can't talk about the number of immunizations in 2023, 2024, the number. That's one way to measure it. Others in terms of the allotments of geography, how many census tracts, how many beyond that. But I think for us, it is understanding that almost everything started a movement. I think the vaccine movement, although it's decades old, now has new life. And I think we need to seize the moment with the message of hope. I think that movement, an initiative, and hopefully their missions as a part of organization prior to this time only looked at health as being in certain facilities like medicine. The health has been broadly defined now, and that's extremely important. But I would say that our measurement is in the degree in which we are able to sustain ourselves as change agents. So every year, what we want to do with regard to health must expand, because we have yet to create this healthy environment. And it ties to voting. So we go beyond the provision of basic health care. I would tell you how important it was to me this month. Said I developed Moderna, and I could take that message, that face, and there were people who could not stop from talking about Dr. King's mindset for that, who said, I developed this for you. And so that's the trusted messenger, and that's the other piece. I think when we become those change agents, we understand that we're here for the long haul. And that it's, as my fellow panelists said, it's not a drop in, it's even more than not a drop in. It takes me 5 to 7 years to get ready to build housing. So it takes much longer. And then we're ready to pass the baton. The success is that we don't drop the baton. We have to wait to pass it on. And so we know that as we romantically talk about standing on shoulders, those shoulders fall, and that we can see future generations and persons pursuing the field. And we're able to deal with some of the younger people who are in AP classes, and looking to advance themselves in ways that are very different. In our public school system, that we see the engagement there, beyond just go to the health clinic and come back with evidence that you had your shot, but you're bringing it in. I think success has to be redefined, with an intention of being sure that we are empowering our communities, and that future generations will carry it.
Excellent, thank you.
Can I just add one more?
Of course.
One of our affiliates, Alina Medical Health Centers in Chicago, and just to take a little bit off, to connect a little bit what you just said, right? On taking, vaccine efforts outside of the health clinic. Alina Medical Health Centers, they work with their consulates, and specifically the Mexican consulate, in which I had an opportunity to go visit, and I did not realize that they are larger. Chicago, larger than the one here in Los Angeles. In the Mexican consulate actually serves multiple populations in Mexico, and they are able to provide linkages for other communities that come through the or just giving back to the community that we're serving in that area. Communities all the change, so forth. So when you come to the partnership that Alina made, they had a long-standing health fair in the same waiting room where there's like that B&B room. They see the numbers popping up from waiting to like all the purgatory and everything. And they have set up health booths where they're bringing they're bringing in resources to address food security, they're bringing in health resources, and also vaccines. So they partnered with Walgreens and they created a little space, a private space, where they not only provide up-to-date vaccine information, but they do a hands-up with Walgreens, who have tech on hand to vaccinate community members who are ready and able to vaccinate themselves without COVID. And that also includes kids. So they have expanded the partnership beyond the Mexican consulate in the Chicago area. They've gone to the consulate of San and Louis, Guatemala, and they're now they're taking this best practices and they're expanding beyond vaccine. They're actually addressing multiple aspects of health, more of that whole health approach, whole human body approach to address multiple needs of the community. So that's story from it really has been powerful to trusted individuals and also individuals who can vaccinate all in the same space.
That's awesome, yeah. Yes, please.
How many know St. John's? Do you know where it started? That did someone just had got funded. It started as a health fair at St. John's Episcopal Church. And for many years it operated there. And it grew and expanded. And look at St. John's now. I would imagine there's some others, but that one is one that we should take as a model, a case study. Because it started with persons volunteering and understanding, and primarily populations that could not be served in public sector safely, or the patients felt they didn't understand. So I think that many models around show successes, but what is the saying? Replication is the greatest form of benefit.
Yes.
That when we actually see something being replicated.
I agree. So, so as far, just on that note, and I noticed too that St. John's is very active with legislators too. I mean, just to increase awareness of.
Yeah, I'm sure that's part of that, when you advocate for populations, you develop a voice, again, a trusted voice, and you see what you're exposed to. And I'm sure that's been a huge part The United Health Plan. That is now a major, it's a major. It's a national agency. Which are affiliated with the White Health Foundation. So there's so many examples, and we think of those as being a few and far between. But I think again, those are people who were tenacious, who were change agents, who believed in it, who did go out and advocate. So then you have a system that comes not only from the government, but you have Affordable Care Act.
Exactly. So, and the good thing is we have a few more, we have time, so I feel like it would be great to touch on a couple other things here. So I can see you're both strong advocates for health and immunizations. So I was curious, can you share some of the key strategies and approaches you've used in your advocacy work to raise awareness among policymakers about gaps in vaccine coverage and the need for improvements in the adult vaccine delivery system?
Well, we start by voting. And being advocates for things are important, not just obviously on ballot, but in ways that are connected. The actual presentation that was here this morning, where it's very, very clear and stood out to me, and you mentioned transportation being a huge barrier, but housing is another one. And while we are addressing homelessness in a way that we are rescuing people from the street, there is a bigger picture. And I think as we look at the issues that even on this ballot, in November 5th, we see major housing initiatives. We have to help people tie that to health and help us. We, for example, one of our projects is currently a shelter. We're required to operate as a shelter for at least 3 years while we plan for permanent housing. And so what's important to us is that that's an opportunity that came to us because public officials saw our advocacy. And sometimes they don't want to see you coming, but you never let that stop you. The opportunities to share information and hearings, because I promise you, people who are lobbying for legislation that is not in the best interest of the public, absolutely in their office. It's important for us to take advantage of and to invite them to see the work that you're doing. Because we will offer the opportunity to have this project because of the work we have done. So your track record is important, but being relevant and continuing is very hard because when you're in the trenches, you don't have the time, you don't have the resources. But it's important to weigh in. I think the other is volunteering on boards and commissions. I volunteer on that. And thank you for your support, Go Metro. It's important that when we see the kinds of things that are happening in the system, that we're able to give you real information about real protection. Most of us have watched the hijack. The fact that the barriers were up was very important in this type of help. It's not visible. The things that people are trying to do to us are greater. So we provide them. We also provide with them in ways of having safety systems. Health is tied to equity. And many people don't see the connection, and you are uniquely qualified to do that. The challenge, I think, for all of us is many of us in positions where we do something every day that becomes almost routinized, and we take it for granted. But if we do our job well on a regular basis, always pay, and we're even creating a mantra and saying the same thing at the right time, someone who we thought was not paying attention will remember what we have said and will repeat it. I think the new marketing strategy is it takes 37 hits to get attention and 7 more to get action. So we should never give up. We think it's happening. So I think with policymakers, I have found many of them come back because they do want that trust and informed voice at the table. And even though they might not want to see you critical times when they're struggling with a decision, you never regret having done your very best at the right time. It is so good.
Yes, absolutely.
And I'd like to share, at OELS we are a civil rights advocacy board, and being based in Washington, DC, we do have partnerships across the aisle around various topics. I focus on health topics, and work very closely with our legislative affairs team, who are the lobbying side. And we've been working with Senator Shop office from the Democrat from Hawaii to support and endorse and advocate the National Immunization Program. It's called the Known as Vaccine for Adults program. In the conversations that we've had with their office, we focused on two specific areas in making recommendations on the technical language of that bill. And one of those was to ensure that the definition of a vaccine eligible adult include uninsured and insured. And we worked to refine that definition. To go back and forth, but they did accept our recommendations. And the second addition that we reflected was around ensuring that vaccine education did not remain only at the provider level, but allowed community supports to also tap into vaccine education. Because we know that community-based boards are where our trusted messengers reside in many areas. So that is some of the federal advocacy that we've been doing and ICLAC. Aside from the federal advocacy side, we also just recently held a 2-day convening vaccine program. We brought in 20 of our funded affiliates. We brought in national BIPOC organizations, the National Urban League, Conference of National Black Churches. We also brought in the American Pacific Islander Health Forum. We also brought in Northwest Portland Tribal organization and a few other government officials. We have representatives of the White House, representatives of HHS and CDC in the room to host a conversation on how do we sustain our efforts, how do we bring collectively our resources to ensure that we are continuing the fight is not over. And of course, one of the biggest conversations in the room was funding. And that funding is no longer here. And one of the reps from the White House told us funding will not be here, most likely. So continue the fight and continue to do the work because we must continue. So that is more on the federal, I would say on the top side of things. On the local side with our affiliates were able to utilize the data that we provide on behalf of the program. The program is funded to pull together stories, impactful stories of what it meant in terms of the return on investment of funding, and they package these stories to go to their local communities or local field days, whether at the state capitol, to be able to talk to their legislators around the impact of this program and the vaccines have had in reducing disparities in the community. So by being able to use data as well as human-centered stories to communicate those impacts to our legislators, that is another form of community advocacy that is also very important tactic in order to continue to advance the.
Thank you. Yes, and to your point about the passion, it's very impressive that it was a very diverse organizations. And, when we look at kids or information, having culturally competent materials is also very important. So for example, we're in LA County, there's about 160 languages or something in LA County. And I personally have experienced going into communities where English materials was not cutting it. And in some cases, Spanish was not enough. We had Korean, Chinese, Hmong, there was a list, and literally I had to carry GIS sheets in almost every language, or at least direct people to the website that the CDC has with all of the languages for different disease states. as well as vaccination. So that is phenomenal that you have partnered, both of you, that you have partnered with so many organizations that made an impact. Because if it weren't for you, then there'd be a lot of people who would have no idea what our efforts are about. So, go ahead, Ms. Jacqueline.
I just wanna take a message for heartfelt. I'm not fortunate enough to be able to support. So we have to find other ways to get our message. The responsibility is so key. If you watch any of our public meetings, and get to the public comment section, have you noticed who comments? Not the public. There are people who see it as their job to show up and say things that make no sense and to curse the policymakers out. We have given that section away that was designed in our system of democracy for the decision makers to hear. We need to reclaim that. The pandemic again made it easier. You can now do it on the phone. You don't have to show up. You can speak from the experience you have in your institution, but not on behalf of the institution. You can speak personally. And I would say that it's very, very important. We can actually have gatherings of our community and you can actually show. I have 60 people sitting in this room and they want me to say to you, that's how we did that when we redistricted. I think we must reclaim that voice so that as the policymakers thinking about it, because most elected officials, I work with elected officials, it's no secret, we count those voices. Every letter has a multiplier. Every phone call has a multiplier. And so that voice is speaking for voters. And how do I get to keep my job? Voting. And so I think we need to claim that back. We have basically professionalized the voice. And we must claim it again in order to get kinds of elected officials that we believe are tied to the community, will understand the value of remaining engaged with us after the fact. And so I really want to put big picture out for that. We have the professional campaign directors who will tell us what the results is going to be before we vote. But we can turn all of that around by voting. Because that's a projection based upon the calculation who's not going to vote. And every failure to vote is not a good policy. And so all of us who are eligible to vote, we should. If we're not eligible yet, guess what? I have an obligation to find an eligible to stand in as my proxy. So all of us need to reclaim and for policymakers that personal responsibility for conveying, not just at the ballot box, but afterwards, consistently. Because the grade that person gets as a policymaker is, I promise you, every policymaker I know, when they see the people show up and speak, it makes a difference. And that's why when someone shows up, it makes a difference. And I'm only non-elected official on the board, but I believe that I'm there to be the voice of those people. So I'm listening very hard because elected officials are there because they're elected for another office, not the mayor. So they have that piece. I will say to you, in this field of health, tying health in every decision to quality of life is a wonderful opportunity.
Thank you. Great. Well, very exciting. Thank you so much, Jacqueline and Pedro, for all of your time and sharing your wisdom. And with that, I'll pass it back to Irene.
I do want to just open it up and see if anyone in the audience has questions for our panelists. We can take a few minutes and answer any questions you might have. Just raise your hand, I'll walk around the line, don't be shy.
Sure, Saffron.
And we can leave those at a table in the back and we'll have some time for networking as well, so I encourage you all to stay. If we have no questions for the panelists, I will just move to a few closing remarks. You all feel free to sit or stay, whatever you're comfortable with. But thank you so much. Thank you. Please give a round of applause. Really valuable expertise shared. Thank you so much. Okay, so just a few last closing remarks. I did want to let you all know that a link to the presentation slides will be shared with you all within a few days, so you'll have access to all of our slides and resources. Please also complete our evaluation and post test. The QR code is on your table. This link will also be emailed following our forum today as well, but if you want to go ahead and pull it up, you're able to do that. There are continuing education units available for RNs and LVNs, so please be sure to get your 2 credit hours if that applies to you. That's on the evaluation, and the deadline to complete that is by next week. Please do sign up for our newsletter. It's a great way to receive information about our upcoming events, resources, other activities that our coalition is involved in, and my contact information is included there if you want to reach out to me if you have any questions or other thoughts, suggestions. We really welcome all of that, but really just want to thank all of our presenters or panelists for giving their time, for sharing their valuable input, for all the advocacy work that they're doing on the ground to keep our residents safe locally and nationally. So really impressed with everything going on. And thank you so much for sharing. I hope you all were able to take away some points today too. Thank you all for your questions and engagement. I do encourage you to stay for our networking portion. We have this space until 1 o'clock. Please mingle, connect with one another, ask questions, speak with our panelists or presenters if there's anything else you're curious about with any of the information they shared or presentations. But with that, thank you so much. Hope to see you in the spring. Yes, definitely.
Housing and absent. One of the things that I personally fail to do is to remember that affordable housing by its physical definition embraces all of us. The definition of affordable housing is that no one should pay more than 1/3 of their income for house. That means if I'm a millionaire and I'm paying $600,000, I don't have affordable housing. So that helps us understand that quality of life is really important. However, with the first funding for affordable housing, the ceiling was 120% AMI, average median income. That translates into, if I'm a family of 1, then I can actually earn up to 100,000 and still qualify for some housing. So we have given people the impression that if you're not at the 30 and 40% level, there's nothing available for you. That's not the case. So a lot of our housing does have the 60, 80, and 120% of median. Now, I'm happy to say for a moment and give you some of the prices. You can spread the word. You don't have to move to Lancaster or the Inland Empire. Once you retire, there's some here in the community here work so hard to build. Hinting and getting the information out about 120%, 80% for AMI or affordable housing that you can qualify for here in the city.
Please speak up and take those resources. Great, that's all I have. Welcome you to stay. And again, thank you so much. Thanks to everyone who joined us virtually. Are there any last questions or comments from those on Zoom? Please raise your hand or put something in the chat. We'll just maybe give like 30 seconds.
Thank you.
Okay. All right, well, thank you so much.